No, lower please. It is February 29th, a leap year, I've been told. 2024. We are here with a patient who happens to be a bull rider, but also a professional in other ways. I can't tell you too much, but I think the bull riding's okay. Today we're going to be doing L5-S1 Deuk laser disc repair, bilateral 4551 Deuk plasma rhizotomy for facet joint pain, and then bilateral piriformis muscle releases. He has disc pain at L5-S1, facet joint pain at L4-5, L5-S1 on both sides. He has bilateral piriformis muscle tears and pain. And we'll be doing a release in just a moment. Shot, I think a little too far south. All right, we've just got a lot of exposure here. How's he doing? Sounds like he's sleeping nicely. Num num? Everything okay?
Yeah, I'm just trying to reconnect this mask.
You want me to hold up?
No, that's fine.
All right. So, why do disc injuries cause back pain? Henry, you want to show our audience our why do disc injuries cause back pain video? Yeah, that's good. Welcome back. And now you understand from watching our animation, I hope, why a disc injury can be so painful. It has everything to do with inflammation that's happening in the back of the disc. Is he okay? Just coughing?
Yeah.
All right. Now our patient is not intubated. He is sedated. And our goal here is to do the surgery without putting the patient under general anesthesia. Shot? Typically we're able to do that. Oh, shot. L5-S1 can be challenging to get to. Shot? All right. Are you happy with me proceeding?
Yeah. Yep. We're getting good respirations now.
He is a very strong guy and very powerful. Shot. AP. So we are now within the foramen at 5-1 on the right side. I need to look at where we are in an AP view. He is snoring. We need to be more medial. So I have to pull back and try to go back in again. Shot. Not too bad. Shot. All right, while I'm working on this, let's let's go ahead and play another video, Henry, of how the surgery actually works. And let's use our new video. Sean?
Not a problem.
All right, welcome back. Now you can see from our animation that we are going into that tear in the back of the disc where all the pain comes from. We're using a laser to clean the tear because what's stuck in the tear is a herniation. And that herniation is causing severe inflammation. So the body's response to the herniation is to attack it. And the reason it attacks it is it doesn't know it's part of the body because it's been hidden away inside the disc for the whole lifetime since the person was no longer an embryo. Shot. See, as an embryo or fetus, you have these tissues that are there, but then they disappear as you develop. And one of those tissues is the notochord. Notochord, notochord, which is an embryological tissue that, yeah, take your time. It's an embryological tissue that orchestrates the development of the germ cells like endoderm, ectoderm, mesoderm, which become your muscle, skeletal system, brain, heart, lungs, kidneys, organs. So the notochord is responsible for causing the differentiation of less developed stem cells into those tissues. And then once the notochord is done doing that, it literally goes away and becomes, tell me when, the nucleus pulposus. Take your time. The nucleus pulposus is the jelly in the middle of the disc. So when you get a tear in the wall of the disc, you're releasing the jelly through the tear and out. And a lot of people think the herniation is the part of the jelly that's outside the wall of the disc, but it's actually also the part that's stuck in the wall. We call that the interposed nucleus or interposed herniation. And that's the part that hurts. Take your time. That's the part where we are right now. We are right there, and that's why he's responding, because he feels it. That's the painful part of the disc injury. So what we're going to do today is go in, find that tear, use a laser to clean it up, get rid of the herniation stuck in there, clean up the edges of the tear so that it'll heal properly. And the pain from the disc will be gone once we do that. We're also going to fix his facet joints. His facets are injured as well. So whatever he did to his back, he did to his back and his facets. Take your time. Yeah. We could start with facets if you want. Let's see. But he's very sensitive. Because that disc is painful. Why don't we go ahead and take the guide wire out? Shot. We are in like Flint. We're good. We're good. Yeah, we're good. This is the worst part for the patient because this is where all the pain comes from. Is that sterile?
I like it.
It's okay?
Of course, I put it like that. That's for my guys.
Oh, I know what it is, but alrighty. Come out. Should be good. Shot? Oh yeah, we're in good. That's fine. As long as it's appropriate, okay. So I'm going to pull the tube back a little bit as we work, but we are in the tear, past just at the base of the tear where the herniation starts. Oh, I see. That's what that is. I understand now. That's our marker. Is our irrigation on, guys?
Yep.
Scope on, irrigation on. All right, let's get the irrigation on. Come on. Let's have it ready to go next time. And there is your pink inflamed tissue. That's your inflammatory tissue within the disc that's causing all the pain. Remember you saw that on our video, right? Henry? It's pretty obvious, isn't it?
Yeah, of course.
Does the animation do a good job of explaining that?
In my opinion, it goes above and beyond. I love it.
Wonderful, wonderful. All right, if there's questions, feel free to type them up, and Henry will relay those questions to me as we proceed through the surgery.
Everyone I showed it to
Damn
loved
it.
those graphics. The animation. Really nice.
But did they understand?
Yeah, I think so.
That's the most important thing. Do they understand the source of pain and how we fix it? That's really, it's a story. The animation needs to tell a story effectively. Any questions from our audience?
Yes, we have a question from Tom on Facebook.
By the way, there's the tear right there, the blue and the
We-
white.
We can see it, yes. This question from Tom on Facebook asking, I'm sending you my MRI today. I had many spine surgeries. What causes extreme lower rib pain?
What causes extreme lower leg pain? Well, Tom, there's a few things that could be causing your leg pain. One is you could have a pinched nerve in your back. Two, you could have a pinched nerve in your buttock from a piriformis syndrome. Number three, you could have venous hypertension, venous stasis disease from incompetent vein valves. Number four, obviously you could have a tumor fracture or a undiagnosed bullet gunshot wound, we call it, which I'm sure you don't. There's also reflex sympathetic dystrophy, RSD, otherwise known as complex regional pain syndrome. I don't know exactly. It depends on the distribution of your pain, where it's located. I need to see where your pain is with my eyes and then use my experience to figure it out. But those are a few. So foot problems like joint problems, sprains, venous problems, circulation problems, usually venous hypertension, venous stasis disease, pinched nerve problems in the back or in the butt. Those are the main reasons. Luis, am I missing something? For those of you who have never seen this surgery, that is a laser fiber. The laser itself is a machine the size of a big suitcase. It's located at the foot of the bed. In our new website, you'll be able to see what it looks like. It's a Holmium YAG laser. And we have we have 10 of them. 10 of them, 10 of them, 10 of them. In anticipation of growth. So, anyway, we've spent the last year collecting lasers. Right, Luis? This is the herniation right here. You guys can see the white stuff is scarred herniation. It's really thick. Anyway, the laser itself is 1 millimeter, 1 millimeter wide, the glass. And you can see I'm moving it around. That's me moving it, by the way, the surgeon. I'm doing that because I'm targeting specific areas with the laser. I'm trying to get rid of the herniation, clean the tear, and the herniation often will become stuck to the annular tear as it's trying to escape from the disc and go out to where the nerves are. And that's what we're cleaning up, that area right there. So this is where a lot of his pain is coming from. You see the blue color? That's the dye we use, the Deuk spine dye. And that dye will stain to only degenerated nucleus pulposus. So it has to be herniation. There's nothing else it stains to. It won't stain to the bone down here. It won't stain to the blood vessels. It won't stain to the annulus. It won't stain to scar tissue. All of those things stay white or pink, but the only thing that turns blue is the herniation. It's called degenerated nucleus pulposus. So when you see it, you know you're in the right place. Any questions?
Yes, we have a question from Betty on YouTube
Hi, Betty.
asking, can you have 2 tears at one disc?
Yes, you can have 2 tears at one disc, one on the right, one on the left. If you have 2 tears on one disc, one on the right, one on the left, and you have symptoms in both legs, then you need to have both sides operate. We can do it. Now, once again, this patient has one bad disc causing pain. He's got facet joints causing pain, which we're going to fix next. And then he's got the piriformis muscles causing pain, which we're going to do last. We're going to break it up into 3 separate streams or videos, even though we're doing it all in the same surgery. The reason for that is we want to be able to show people that they're distinct procedures, separate procedures, even though we're doing them all at the same time. Okay? So, oh, he is snoozing. He is snoozing. What's wrong? Everything okay? Any more questions?
No current questions, so we do have a comment from Tom once more on Facebook saying, I can't wait to meet you as I'm in unbearable pain for the past 8 years, many surgeries, but no hardware. I feel that you can give me my life back.
Oh, we can definitely give you your life back. Yeah, there's no doubt about it. Tom, thanks for saying that. And since we're on the subject, the causes of back pain, we have shown you a video that talks about one cause, which is the disc. The disc injury happens to be the most common cause of back pain. 87% of patients that we see here with chronic back pain, like you, Tom, have pain coming from a disc or 2 or 3 or 4 that is injured. And not only do you have that pain, but it is the primary source of pain, meaning the main source of your pain. So if we don't fix your disc, we ain't fixing your pain. Now, when people get an injury to their disc and they get discogenic back pain or neck pain, they usually will injure other body parts either at the time of the injury to the disc, which is the first thing that happens, or they'll injure things later on, you know, as they do things, like they bend improperly. You know, I'm now 54 years old, and I'll be honest, when I was 18, I could bend over, pick things up, and I bent differently when I was 18. Now, you know, to avoid bringing on some pain, I bend differently, and that new way of bending is not the right way of bending, and that can cause more injuries. So what happens is people in pain, they end up bending and twisting and walking and standing in a bad way that causes more problems and more pain. So it's a vicious cycle that people are in. And it's real simple. Fix the pain source early on before it creates more problems. That's what our philosophy is. Now, a lot of other doctors are just going to send you to physical therapy. It doesn't work. They're going to send you to chiropractic. It doesn't work. They're going to give you pain meds. They don't work. They're going to give you nerve agents. They don't work. Everything they do doesn't work. I know because we have tried them all. And when you have a disc injury, there's only one thing that works, and that's disc surgery. And I don't mean a microdiscectomy. I mean either a Deuk laser disc repair, this exact surgery you're watching, or a fusion. Those are the two treatments that actually work for disc pain. Now, I used to do just fusions a long time ago, because that's what I was taught in my training. But then I learned about endoscopic surgery, and then I learned about lasers, and then I started putting the two together, doing this, what you're seeing right now. 17 years ago I started doing this surgery, and lo and behold, my first patient, when they woke up, I said, "How's your leg pain?" They said, "It's good, it's gone." I said, "Wonderful." I said, "Now we just got to fix your back pain." And they said, "What back pain?" I said, "The back pain you had." And they said, "It's gone, doctor, it's gone." I said, "What? We just did unpinching your nerve root, but we didn't fix your back pain." They said, "No, you did, because it's gone and it never came back." So I realized this surgery was the key to fixing back pain at that time. I mean, it wasn't with the first patient, it was after about 5 of them. But the results were so amazing that I was onto it right away, and I realized we had something here. That somehow we were not just fixing leg symptoms, but also back pain. So then I started to think about, what am I doing here? And that's when it dawned on me. We're cleaning out the tear. That's the key. Prior to that, I was fixing back pain with fusion. And I thought everybody had to have either a fusion or maybe an artificial disc to get rid of their back pain, but lo and behold, this thing targeted it dead on. And no need for fusion. The patients we did 17 years ago are still pain-free. So, or dead.
How much time we have here?
We're still paying free.
Well, we have, yeah, they're still pain-free. With the disc, 5 minutes max. 5 minutes on the disc, then we're going to go to facets. So Henry, we got just a few more minutes before we turn this live stream off, and we come back with the facet joint.
Copy
Any
that.
more questions?
Yes, these next 2 questions come from Kieran on YouTube.
Kieran,
Kieran, yes.
nice to meet you, Kieran. Welcome.
First question they ask, if an L5 to S1 hernia is large and has a caudal migration, would you still be able to push it in with the dilator before pulling it out?
Kieran, great question. So for those of you listening, what is caudal migration? He's talking about a herniated disc at L5-S1, the hardest one to get to. And then the disc not only came out backwards, but it also went down towards the feet. And it's locked in there behind the vertebral body, locked in there in front of the facet and the lamina. And they are hard to get to. The answer is no, I can't get it all. I can't get it all, but guess what? I can never get it all. We never get all the herniation, not with any surgery we do. As a matter of fact, no surgeon can get all the herniation. So yes, there will be some pieces that have moved down caudally and we cannot get them. But we don't need to get them. It turns out you don't need to get every piece of herniation to get rid of people's symptoms permanently. You got to get about 50%. Of course, it's case by case, but 50% is the number you can remember. Don't expect to do this surgery and wake up and get an MRI and you see everything is perfect. That's not what happens. Once your disc is damaged, it's always damaged. There's no way to go back and undamage it. Okay? It's like cutting your skin. If you cut yourself, that skin will heal. But you'll always have a scar. It's never going to look normal. That doesn't mean the scar causes problems. It doesn't. It's just you don't like looking at it, but it's there. But point is, your body did its job. It healed. Okay? And the pain and symptoms from the cut go away. But the scar never goes away. When you damage your disc, there'll always be some herniation left. There'll be some stenosis left. The point is, we're not trying to make your disc look normal. We're trying to make it feel normal. Damn, that's good. Huh? You like that? All right, who's next? Question number 2.
Question number 2 from Karen, once more on YouTube, asking, excuse me, asking consequently, if there were to be some fragments left in the extrathecal space, what is the probability of that getting impacted in wrong places before getting absorbed?
First of all, those fragments will never be absorbed. Second of all, the probability is 0. You got nothing to worry about. We're pretty much done here. We're done, yeah. Oh yeah, this is the worst part right here. We're there. You're doing great. Hang in there, buddy. All right. So some people know that when I first started doing lasers, come on, let's go, quick. That I actually lasered myself accidentally with my finger. The laser broke. We're pretty much done here. And when it broke, it where's the tube, the dilator? The laser broke. It snapped right in the tip of my finger, and it my foot was on the pedal, hitting it hard. In other words, I lasered my fingertip. If you look at my pointer finger on my right hand, right here, you'll see a scar. It's been there for 17 and a half years. And the reason that happened was, people say our laser's dangerous. They can be if you don't use them properly. Oh, look at that piece of herniation. You guys see that? Right there, Henry?
Yes, we do.
Here, take this for your specimen stuff. Anyway, what happened was I was twisting the fiber, trying to get another piece of herniation out. Twisted a little too hard, it snapped. Remember, it's glass. As soon as the glass snapped, it created a fracture through the glass, and it created basically a reflective surface that shot the laser energy right through the plastic coating, the blue coating, and then straight into my fingertip. Man, I can tell you, that hurt. It hurt bad. Shot. All right. Oh, by the way, you got to end the broadcast. Sorry, Henry.
Copy that.